Enjoy Dr. Christina Bethell's keynote presentation from the annual convening of the Early Childhood Developmental Health Systems Evidence to Impact Center. Please be aware that the internet had some hiccups, causing the presentation to take an unexpected turn. We've synchronized the presentation slides with the audio recording, removing any technical glitches. We hope you find this video informative.
So we have till 10:45, and I am going to share a lot that I imagined you would want to maybe know in a way that you might want to know it. But I really want to let you know that I can only imagine that. And so if there are things that I'm saying along the way that really you want some sort of compelling question or something to help you, please do interrupt me, okay? But otherwise I'm going to go through and then we'll leave as much time for questions, and then there'll be a breakout as well where it's kind of free choice for you where you want to dive in, but I'm prepared, for wherever you want to go. Okay, so my talk is really about meeting the moment, and the moment exists because of the decades of work, hundreds of years really of work that we're sitting on, the science, the people, the leadership that's been passed down, the will, and now really the compelling vision that many states and the nation have. Sorry, I'm not sure how that came up. And I'm also working with the National Academy of Sciences Child and Youth Wellbeing Committee, and these are the themes. These are where we have to make an impact in financing and policy. So we have this shared aim, which I really feel is the biggest strength, the biggest meaning of this moment, is that we have, I think, a shared aim that's sitting on solid science with real pillars of action that we know we can take. We have evidence-based interventions. I'm looking at Alan. We have, policy innovations, but we haven't broken through yet to really, really fund those and anchor those in all of our systems. So this work is so important. And I would say for me, the science says one thing that we have to really embed in everything is that we are built for nurturing connection. My body remembers Colleen, and my nervous system is regulated by that. And when I don't have that, it's dysregulated. And a lot of us are walking around without the connection, and because of our trauma, because of just not knowing. And so relational health, which is a term that Dr. Willis has coined, but that we know is at the core of the science, really is what we have to make sure we're at the watch of, that is embedded everywhere, so that we don't go into language that forgets what we're really talking about in terms of the needs. The CAHMI has been around for 26 years. We just published a paper with Colleen and others, and Nora Wells, who I don't know if any of you know her, but she's was president of Family Voices, just retired, and others, on family engagement and family voices, and really embedding that into measurement and policy. And that's really been the core of the CAHMI. And our goal has been to define what we're up to consciously with intention, to look at actionable data, measures, tools that can be shared and used in transformational partnerships that then work toward those goals with a feedback loop and continue. So that's sort of the three-part theory of change, if you will, that has not changed. I keep thinking, well, let's just change it up, but we keep coming back to this, like those are the things that we're gonna really focus on. And I do want to do a disclaimer that I don't have financial relationships to disclose, but I do want to disclose that, like all of you, I know that every success story is a relationship story. And so today I want to further reinforce our why, and I did some data work on all of the states, but I didn't know about the 4 new ones. So I feel bad about that because, I probably wouldn't have been able to help myself, but for those of you looking at the data slides, I'm happy to create them also for the other states. And then to deepen our knowledge about the EnAct framework as a model for, to maybe facilitate your work in some way and a systems approach. And then also to identify application opportunities. So I'm presenting this now and in the breakout in a way that really help you figure out what makes sense, what doesn't make sense, where you can gain some benefit from the resources that are here, that are really building on all of the resources that had come before. And then also as we go to think about what the core skills and mindsets are that are essential. They're obviously flowed through everything, But there are many of them, and without that, we don't really create systems change. And so to just sort of reflect on that as I go and hopefully celebrate that you're already there in many ways, but who isn't? Who among your partners needs to be brought along? And they're humans, and how do you bring people along into a mindset that they might not be in, and why are they not there? You know, pediatricians weren't necessarily trained to do this. There's fear. It's often fear, right? And so how do we get good at presenting vision in a way that keeps people connected to possibility versus their fear that they might not do it right? So we're all just people, and how do we shift mindsets toward a possibility that we can share? So those are objectives. But first I wanted to get to know you, getting to know you. And I actually did create a little song as I was doing all the data, and it went, Arkansas, Massachusetts, New Jersey, Oregon, Colorado, Hawaii, Washington, me in my apartment. So I'm not sure. I just thought I'd share it with you because life is, you know, a little intense, so a little levity in the mix. So what I learned, and I didn't know if you knew it, but there's a data table that you can access and that we have with us, is that you vary a lot in terms of just the proportion of children who are actually enrolled in Medicaid. And I know you're also looking at uninsurance, so I have the uninsured data down here. So the variation is information. That's how we can learn, right? When you get your Fitbit and you learn, oh, I slept well last night, I didn't the next night. Like, why? Okay, well, something happened and we can reflect. So I wanted to know you better and get to know the state. So it's a varying thing with half of children in Arkansas being on Medicaid, maybe a different policy leverage when you go to talk with the state in a state where there's less kids. And then there's the money part, which is, you know, what is the percent of the Medicaid budget that's actually for Medicaid for children in your state. And that also gives like telltale signs where it's 21.3% in Arkansas, but 9.3% in Massachusetts. But how much, who's spending, and what's the average spending? Lots of variation, over $2,000 variation in average spending per child. Why? What's that about? What is it in my state that we're spending $5,300 in Oregon and $3,100 or $3,200 in New Jersey? And so all of this is just not integrated data yet, but it's a story, and I wanted to let you know that for me to talk with you today, I had to kind of get to know you. And I'm going to keep sharing this kind of thing when I give different pieces of information. What does it look like for you? And then you can have access to this chart pack and everything else as well. I also looked at your HMOs, which, like it or not, the money flows a lot through Medicaid. And even early intervention, you know, in different pieces, we need to pool resources, right, across all our systems and create those innovative, maybe child well-being trusts that we could get to. But right now, the money's going through a lot of health plans that are charged to then pass it on through what they do. And so who are they? There's 26 of them across the 7 states. And none of them, except for one, has over a 4.5 stars, but when you look into it for the measures that are there for kids, they're just immunizations and well visit rates, not unimportant, but not really the aspirational measures we want that we have access to that we could maybe get in. But right now, it's looking like about, 26 states, and I wanted to pull this data so that, again, I could get to know, well, what's going on? What are you facing? What are you up against, in your states in terms of the relationships that must be built with health plans and Medicaid to start to direct the money and the resources and the energy in the way that's needed to really help providers on the front lines and facilitate the cross-sector collaboration that we know is possible and necessary. And the last thing I did is I took this big survey and focus group thing you did and tried to consolidate it just for my mind. So this may not be the way you would have done it, but so there were 20 topics across 6 areas. And we have a table where I've tried to begin to link resources to each one of these topics so that at least we can get the conversation going and you can get fast track to things. But I learned that transforming pediatric health practices 6, and I'm just letting you kind of glance at this really quickly. So this is really what you said you were interested in, family engagement at the systems level in addition to practice, facilitating communication and collaborations. The workbook that we have is sort of, well, which ones exist now? Where are the gaps? What can we move with? And then obtaining and summarizing and integrating data and measurement, financing, policy, and payment, which we've sort of already talked about a little bit of all of these, and sustainability and spread. So this is what I am coming into knowing about you and a little bit more that I'll go on with. So you can access the resources if you'd like. this QR code will take you to a place where you can just download whatever it is I'm doing here, okay? So we want to start where we want to end up. Who do you think made up that term at the CAHMI? I think it was you, Colleen. We always want to start where we want to end up, right? So what are our goals? What data do we need to help us understand it, and how can we use it? So here we want to start where we want to end up, and this is really where we started with Mississippi. So starting where we want to end up is important because that's where we start, and we can assume a lot about where we are and what we want. We all want child well-being, but what does it really mean? And so for me, I talk about the flourishing paradigm, that when it comes to kids, we're promoting well-being. We're not just looking at preventing things that usually don't occur anyway for a while, unless children are born. Obviously, there are many children who are born with health problems and risks that we can see right in front of us even before they're born. And we want to focus on that. But, there are many children who have no health problems who are not flourishing, and we really want to promote that. So when you take a narrative that's more of a flourishing narrative, it's very different. And I think in healthcare for pediatricians, even though it is about well-being, I think it's still kind of more in even prevention is prevention of something bad, not necessarily promotion of something good. So if we look at the flourishing paradigm, we run into the risks, we run into the problems, but we keep our eye on the prize. And, the World Health Organization talks about this, but we all talk about a lot of things that aren't being implemented. But I just want to say it's a dual continuum, and it's important to remember that we don't have to get rid of everything bad in order to foster the good, that every moment matters, that every person here matters. I can prove it to you. I just got a hug from Colleen, and I feel so much better. And, we really have so much power to promote the positive in the midst, and maybe that's where we get the energy to actually turn the tide on the adversity, is by remembering that. So it's a dual continuum. And the absence of illness does not include flourishing, doesn't necessarily mean flourishing. And if I had more time, I would do an assessment here of just you. And I was just in Arkansas. I don't know if anybody here in Arkansas was in that talk, but we did a thing. And it's about a third of people, or 5 to 6 of the flourishing qualities, and about 2/3 in the lower 2 categories. And so we, even among ourselves, can really support each other in this work. And it's a little bit like the weather system, right? Like some days you sleep better than others. Some days you're feeling better. I'm not feeling good one day, but you are. So as teams, it's very important that we also apply the flourishing paradigm. So unfortunately, however, we need to really lean into, you guys can see it, I can't, lean into the reality with our strengths. And the reality is that the United States is 26 out of 29 in the richer, wealthier countries, and has been over and over again, especially in low birth weight, poverty, and infant mortality, and several education and school success indicators that are now starting to be tracked, and 36 out of 38 in the new UNICEF report from 2020, that's the newest one, and looking the lowest in physical health. And we have 2 in 5 children in this country meeting school readiness criteria, even in our generous assessment. Now, I will talk more about that because I don't want to bum you out, but this is my little bummer section, but I'm going to lift you right back up, I promise. Because we have to face the reality from our strengths, because what is possible is within and between us, largely. It largely is about that. And then, of course, how we use that to influence the policymakers and people who I want to believe at their core also want the right thing, but the financing and really committed financing is key. So I took a look at how many families in the country of children age 0 to 5 say what the overall health status of their children is. And for the most part, most in the country, about 81% are saying their children 0 to 5 are in very good or excellent health status. However, when we look at flourishing indicators, which we have, it's only about 32%. And the bottom line is that only about 31% of all of our children 0 to 5 in the country are both rated as having excellent and very good health status and meeting criteria for flourishing, which is a pretty low bar set of criteria. Dave, he's nodding over there, he knows them well. So I wanted to just set the stage and just say that we do have the new Healthy and Ready to Learn measure we've published on. It's 2 in 5 children meeting the criteria. You can look at whether you want to score it differently, but no matter how much you torture it, it's not very high. Lots of variation across states. That's exciting. Where there's variation, there's information. States vary. That means we can learn from each other. It's really great. And this is what it looks like in a measurement schema that we've created that I can share with you in depth across the states. So there's a lot of variation across the states. So just like keep yourself out, because it's early learning skills, social emotional skills, and focus and attention. It's higher for any one of those, but when you look at a child level, it's very low if you have all three, right? So if we separate things out measurement-wise and not look at the whole child, we can say, oh, we're doing great. But if you look at a person, I'm a person. Like, I need to both eat and sleep and have water and get hugs from Colleen, right? It's like I need it all. And so I think that that's why we often look at these composite measures, and then we can unbundle it to see where we need to really hone in and make improvements, right? Unbundle data all the time when we can. And so we are very fortunate to be sitting also on all of these, Bright Futures guidelines, bless their heart. It's in there. It's in there. I promise you, if we could get it done. And all of the organizations, many of whom are in this room, that have set forth that well visits really are a powerful opportunity because they're paid for. They come through that funding stream where money is, but they can't be done well without integration and family engagement. You know that, I know that. We're talking about it, so we're going to keep going here. And so they're important for a lot of things, not just screening and not one-off screening. You don't want to just have developmental screening over here and maybe 2 months later maternal depression. I think you need to see the whole child to make sense of it, even clinically, and to really focus on what families want to share and what their priorities are. But they don't even know what they have to choose from. They don't know, oh, I could talk to my doctor about my child's behavior. I can give you so many focus groups, so much. Families don't know across the income spectrum what the possibilities are. And Marianne Earls was saying earlier that many providers don't even know that that's what they're supposed to be doing. And so what can we do about that? But we have a huge opportunity in the first few years of life. And it's also the law. Now, maybe that doesn't mean a lot. What are they doing about this law? I don't know. It's like EPSDT, right? It is the law. It is supposed to be happening. And how can we really get the data into the hands of those who can advocate? Now, it's not always our health systems that can do the advocacy, but families and community groups can. And they don't know about these things. And when they know about these things, they can have more power to say, hey, you're supposed to be doing this. So Section 2713 of the Affordable Care Act does require, and we have lots of synergy across many of the programs in what they're being required to report. But again, is that data being shared with us? Do you know it in your state? Do you know what your rates are? So I'm going to share a little bit about that. Right now, the best data I can get together, and it's a little bit like a triangulation because there's no really great data on well visit rates, but about half before children visit school happens. So there's about 57 to 60 million visits that are supposed to happen across children 0 to 5 a year. And about half of them happen, and it varies across states. So this is based on a CMS measure, which is tracked and reported, of how many families, how many well visits occur that are supposed to occur, 6 out of 9. So that means that 9 is not really going to happen, right? So if you've got 51.4 that have 6, you know it's probably in the 30s somewhere for all 9, right? So we're missing those key early months, which we know are so critical. And so this is from CMS, and then this is from our analysis of the National Survey of Children's Health, which does not do the great job I like it to do, but I at least can tell you who clearly did not meet criteria, because they're 4 months old and they didn't have a well visit, or they're 2 years old and only had one, that kind of thing. So it's about a third of children across all the states that didn't have, clearly in that 0 to 35 month, that did not have a visit. But we know it's more because we can't strike the data. But this is a little bit of a roadmap to help you see where you might be. And then for medical home, how many are familiar with the medical home concept, which has 7 domains, and we measure it? Your data is available on that. It's still around 48% for all children 0 to 5, and I thought for sure in my naive, I think I'm going to always be naive in a good way, because it seems to be an optimism gene that I have, but when we started measuring this, I thought for sure when we measure it, we're going to use this data and we're going to improve. Again, measurement isn't valuable. Data is not valuable unless you're using it to do something with it, and because you haven't actually changed. It's very, I need some group energy, and you may need it too, to keep me in the game sometimes, because it's not changing, but it is changing. I'm hoping it's just going to be a breakthrough, but the medical home concept is a sound one. It's aligned with a lot of what you say you're trying to do, and we're about at half kids in the country. And about 1/3 are still being screened for development. Oregon is standing out. What you do matters. North Carolina, when Marion was doing her thing down there, really soared. Our policies matter, but it's very variable across the states in terms of kids that had at least some developmental screening. And of course, there's other ways to measure, but this is what we've got here. And then finally, the real core for me of why we need an integrated system and the data around this is that we have most of our children who have developmental problems or have any concerns also have social and relational risks that could either have driven that to happen or can't be addressed without considering the whole being. Now we know this. We talk a lot about social determinants, which are absolutely critical, but there's also relational determinants, and I think we need to think about those maybe in two different tracks. I wasn't sure, so we did a study, and this is a study at a population-based level that looked at social risks that are evidence-based, meaning we could find lots of data saying when this is in place, this impacts child development and health across life. Poverty, food insecurity, exposure to violence and racism, and unsafe communities. And adverse childhood experiences, the bar for this is 2 or more. Okay, this is a high bar. So 2 or more ACEs, low parental mental health, even good is not good if you know data. When somebody has the choice of excellent or very good and they pick good and you interview them, it's not good. So I'm just looking at fair or poor here. So this is already a high bar. And then also low parent emotional support. Again, parents tend to be positive. I'm doing okay, right? So when somebody actually tells you they're not, it's a big deal. It's true. And so we've got about, I wanted to tell you, 60% of the kids that had those relational risks did not have social risks. So we need to look at a bigger bucket of factors and make sure they're all included. And when we look at it, I'm going to go through and show you the bars and then tell you what they mean. And this is going to be kind of my last big data push before I get right into Mississippi Thrive, because a lot of what we did there was based on this knowledge and this information. So children without any social risk down here, this is this one right here, but 2 or more of those relational health risks still were about 45% with an emotional, mental, behavioral health problem. And when they have 2 of each, it was 61%. So it's 15.3% in the country as a whole. And we have all this data for your states, of course. But, as social risks get added to relational risks, it catapults up. But without any social health risks, relational health risks are still almost 3 times as high, having a mental, emotional behavior. That makes sense, right, with the science in many ways, if we look at the science of mental health and flourishing. And then, of course, for social health risks, you can see mental health without relational health going up as well to 2 times higher, but not the 61%. And so I just want to kind of shake up the system a little bit to make sure that we're blending our relational health approaches in the context of social determinants and not thinking we can get to it some other day, but to center it. And it starts with us. So I have the data for your states. New Jersey was the highest that had both of these, that had some of these risks. But it's about 50%, and of all children in the country with publicly insured, about 57%. So this is a little bit more context on how we're doing, what are we up against, and this was really the kind of analysis that we did in Mississippi and made sure that we went through it. Did people buy into this? What did it mean? And of course it meant that what we thought we were going to do is what we should do, but it's important for each person to have that in their own body, in their own mind, in their own heart, and to talk about their own lived experience. Because most of us in this room probably have that, and that's important to bring to this because there's a wisdom that we have, and it's not just data that we want to validate, and sometimes we have to use data to validate it, but once we've got that lived experience and wisdom and the data to match it, we cannot be stopped. And that is the fire of leadership that we want to put under everyone. And we do need the data, I think, to be able to really, really validate it and give people that extra confidence and boost and also guideposts along the way. Okay, so the good news is that when we promote family resilience and parent-child connection, which we do, we have evidence-based strategies for that. Raise your hand if you think we do. Raise it high. Okay, we do. That's what you're doing, right? And so how do we get those? We just finished an international analysis, and there's other countries that are really doing it, seeing lots of great things, but not so much in this country. But basically, even without any ACEs, this is just one study that we did, looking at child flourishing and school engagement and school readiness. We basically see that if there's no ACEs on board and a child doesn't have these family resilience and connection factors, but they don't necessarily have all the social determinants or anything either, what's the flourishing level? And it was 27% about. And if they had these family resilience and connection, it was 57.6. On the other hand, if they have a lot of ACEs going on, it can really triple the level of flourishing. It's not all that's going on, obviously, but it's a big boost. And in many ways, when families have resilience, a sense of hope, a sense of strength to draw on, willing to reach out for help when they're overcoming any sense of shame or stigma, to really reach out for the resources that are there, stay connected, that actually is maybe the door to being able to take advantage of the social supports that we do have. And we see this lack of uptake where we screen and we refer and then it doesn't happen. And so it's a complex thing, but can we start to see building family resilience, parent-child connection, and provider connection, team connection as a real resource to then be able to really deal with helping people get the social supports that they need and to not, again, disconnect them. So that's kind of it. This is your view of family resilience and connection across the states. There's some variation for sure, 55.5 in Massachusetts, and I'm not going to call it all out, but you can see these later. And then finally, which is different than flourishing, is promoting positive childhood experiences, which is even different than family resilience and connection. Positive childhood experiences are lived experiences. And I can do everything with my child, and they may or may not experience it, right? So the neurobiological hit is in the experience of it. And so we want to just continue to focus on that, the lived experience of our children, which can be signaled by flourishing characteristics for sure. If children are more curious and interested, affectionate and tender, showing certain qualities, you can imagine that they may have had those experiences. It's hard to measure in children. We have a lot of work to do, and I'd love to dive into that if we could measure it more. We have some good observational pieces that Dr. Willis has done, and Alan and other people that the WACs and things like that we need to look at. But we found for adults, looking back on their life, just like ACEs, the same as the ACEs concept, but a positive version, that they were 72% less likely to have depression even with 4 or more ACEs on board. And so looking at this and deepening into it, it's not really new news for a lot of people, but we now have the language and we have some measures, and I think they really support us. So all of this brings us to where we are, that we need to establish relational systems of care. I have about 45 minutes, and I may get faster on this, but I wanted to really lay this out as my one opportunity to hopefully inspire you and bring you to where we are, which is going to be a little bit more descriptive, okay? So I'm going to now describe to you Mississippi Thrive. So Mississippi Thrive is a 5-year effort. It was originally 3, and HRSA kept it going, which was beautiful. And they focused on these areas of workforce development, enhanced pediatric medical home services with some demos there, outreach and messaging, which turned out to, I think, be really the reason their developmental screening rates went up. Isn't because they had a lot of practices involved, but because they started educating families and providers, and just education was huge, and they did a great job with that. And community resource connection capacity growing and getting their feet on the ground with the Help Me Grow model, and starting to create the connections with healthcare, which is where we came in. We started helping them do more. Partner and policy engagement, a lot of relationship building, but when we started, there wasn't a lot of specificity going on and really kind of strategy. And then we came to bring it all together, also coming from our own history of having done different pieces of this work. So that's where we started, and if you want to read more about all the blow-by-blow of what they did in these areas and what came out of it, you can go to the EnAct framework website, and it's right there. But the EnAct framework is what then came after this kind of work, okay? So it did increase developmental screening to the nation from 18.6 to 34. Which one did I do? 34.1, not statistically significant from the nation, still not great, but twice as high. And we think it was really a lot of this, just like relationship building, awareness building, and things like that. So just to keep that in mind. Okay, so this is the beautiful team. It's not everybody, but I just wanted to show you their beautiful faces and their energy, and we met all the time, and we met as a group, and we got into the weeds. So a lot of partners were engaged, some more than others, okay? Pediatric primary care, definitely family-led organizations, health plans, coordinated care organizations, on the side, conversations on the side, but not so at the table. It didn't come to the table. Resource brokers, MFFK, Mississippi Families Help Me Grow, resource and referral centers, definitely the CCDF grantees, the early care and education, and all the resource and referral centers that they have all over the state really have a lot of the same goals as well visits in many ways. Also true for WIC, and many other systems have these similar goals, but they're not working together. And then Head Start, we directly engaged Head Start. We've done demos in Head Start in the past. Early Intervention Part C was a little harder to engage because they're really distraught. I mean, Part C programs are really distraught. They're charged with a lot and they don't have the money they need, and we really need to grab that one. Title V, definitely in McPhee, and child welfare, the infant toddler court program, which I adore. Thank you for doing that program. It's absolutely beautiful, but if you look at the family specialists, they're supposed to do basically the same thing as a well visit. So they need tools too, and you want to meet families wherever they are to get them through every door, which is what really the core of the EnAct framework is about. Already they were operating off of a systems change model that many of you now know. I remember, Colleen, you probably know I used to talk about this stuff back in the day, but it's so great that we're really, really looking at the transformational relationships and mindset. So we had that coming in. So we had a lot of assets and inputs, and there's a logic model template in your workbook that you can have online, and also we have copies up here. And then we did methods, and it's important to know the methods because you have to go through those methods. You can't take them from somebody else's framework and class. It has to become a lived thing. So what were the methods we used that ended up leading to a framework that they could agree on and have senators at the table and do a signing on that charter for that new coalition. So all these processes were leading up to that, and now there's conversations about funding and making sure that coalition can really take on the charge. So there were 6 design-based methods, key informant interviews with a structured set of questions that any state would want to know. And so if you're interested in that, I didn't put it in a packet, but it's like an interview guide. What did I need to know? What did we need to know to be able to get our minds wrapped around this? And what did they need to be able to see about themselves? Kind of like a little of the data I showed you. That wasn't even really clear. Where are we at in the state budget? Where do we live? How many of our kids? Who are they? So this was a lot of learning. And then structured document reviews. If you look at the documents, you'll find rules, regulations, the supposed tos, right? Often the supposed tos are hidden, but they're good to know about because they're hidden. They're not there not on purpose. They're there on purpose, and they often don't happen. And so really looking into the contracts of the health plans, looking into the block grants for Title V. What is supposed to be happening? And we did that, and we have a very long table in Attachment C that goes through that for Mississippi, but it's not going to be hugely different for every state because a lot of these are federal programs with federal funding with requirements that come with it. So that was something that we did, and also looking at all the websites of everyone. What did they already say about what they were doing? And just really the joy that came out of that is there's a lot of alignment here. Let's lift that up and show it in a picture, in a mural that we can all see and feel good about moving together quickly. Data and policy research, of course, environmental scan of really what was going on in the country. The last thing I want to do is create something that's already been done. Let's build. And so I had to be convinced. I remember calling Dean and going, this is my conclusion. Is it true that there really isn't a framework that centers healthcare integration with early childhood? It's not, I don't quite see it. Am I right? I went everywhere looking. And so that is a lot of what this is that's unique about this framework is the centering of pediatric healthcare with the larger early childhood systems integration work that's been going on for a long time. And hopefully they collide in a beautiful way, in a nice ballet. And then finally, the healthcare community partner pre-testing. We did pre-test pilots in community center, Help Me Grow, and also in pediatric care, and a couple of other places, but we created possibility prototypes, which were stories of possibility, but with the organizations that would anchor that, so they're not like made up in our heads. They were reviewed and done with, the home visiting people, like, look at this, does this make sense? Is this what you were saying you would like to do? The resource and referral centers for the early care and education were very interested in this, and they leaned in. So there's possibility prototypes that are 2-pagers that tell the story of what it might look like, and that's also available. It's attachment D, and the reason that's important is that sometimes you can hand out a story and get a long way because you say, here's what you're doing now and here's what's working. Here's the opportunity for what we might do more. Here's how it might look if you did that, and here's what you need to do it. And so that's the structure of the prototypes. And so if they're useful to you, you can take them and just modify them if it's useful to you. And so that's part of the offering of the EnAct framework as well. And of course, what we scanned was awesome. I mean, this is why I'm so excited, is there's so much to anchor to with what HRSA's already done, and AEP, and our work as well with all the stuff I just showed you, and Help Me Grow, and Ink Marks. Is Charlie here in the room anywhere? Kay, I just had an email with Kay. So there's been all that work, as well as the newer framework from ACF that has all the right pieces to it, but was wanting to go deeper, and that was some of what we hope we contribute to. Of course, all the work that Dave Willis has been doing, and Andy Garner, and picking up the research and translating it into a new policy statement, making relational health a solution versus toxic stress the problem. Absolutely exciting and really important for our work. And then CHCS with their work, the Center for Study of Social Policy, and then we looked at 20 different reports that had come out from all these different groups. All of us have done them, right? And how much they had in common. So that's part of what's in attachment B too, is not only the scan and all of that and the references to it, but also the results of our 20 policy report. They're gray literature, they're not in the published literature, so you might not know about them, and putting them together, and you can link to them. And if you've got partners in your community that are resonant with one of those organizations that have one of those reports, you might want to lean into that one and really look at it. It might be the Help Me Grow one, it might be CSSP, but that was there. And then finally, this brand new effort that I was a part of while we were doing Mississippi Thrive with Assistant Secretary for Planning on Evaluation, to go deeper into the layers of literally what would it take to create the coordination. And so we have some of that in this. We have MOUs, example MOUs between the community centers and those sorts of things, and a lot. But this is really very complementary work and an important set of resources to help the states. And what does the federal government need to do in order to help the states, given that so much of the funding for these programs is coming from the federal government? And there was a lot there. Okay, so this revealed that we really did need to explicitly advance a framework that had healthcare as explicitly integrated. To anchor to positive health equity, what would it look like to anchor to really explicit measures of flourishing, family resilience, school readiness, and make sure that that was held up and lifted up as the goal? Detail an integrated approach to services. And so we have a model that we've attached actual tools to, and you can figure out what the tools are in your state, but the model, the components of it, is shared as these things look like they need to go together. And if one of them's not there, it might not work, it might fall apart. It's like a cake. You need the flour and the water and the eggs and all of it, and an oven to cook it in. Specify roles. And so we did that partnership landscape and really looked at the different system change roles that are necessary for a systems change to happen. Okay, there's different roles. Some people are good conveners. Some people have to be funders. Some people have to, work on workforce. There's different really important components, and where already in the partnership landscape are those things being done well? Where's the energy, the resources, the time? And so we did that mapping, and also what was the reason why the different partners would want to be involved? Is it because they had statutory legal requirements, or just because they had come up with a program that they were committed to, or was it just at a mission level? And those are different levels of motivation, right? And they vary. So the Children's Museum didn't have a statutory requirement to be involved, but they did have a mission, and they were important to the work, actually, and they created a sense of community gathering. Did someone want to say something over there? No? Okay. And then finally, to create a implementation roadmap and policy playbook, to take the chance to do the bad first draft or good first draft or whatever you want to call it, to say what are the categories of actions and the outcomes for them that can start to be a roadmap that then you have to tailor for your state and for your local area, but to start to provide something to make sure we weren't missing some piece of the big landscape. At least to help. And then a detailed measurement and data strategy. So I've shared some of the data. We did a very deep measurement scan as well. Shared measurement is powerful, which is why I'm going to go through the next section really fast, because I'm basically telling you all about it right here, but I'll give you a slideshow visual tour in a minute. But detailed measurement, we found 309 measures across the there were 10 programs, and including WIC and Head Start and CCDF and Medicaid and Title V and home visiting, and oh my gosh, they're all there, and that's in attachment C. You have a very detailed piece of it. 71 topics across 309 measures, which means there was a lot of overlap, and 13 that were shared across 3 or more programs, and soon to be 5. And those were developmental screening, maternal depression screening, so well visit rates. So we have a few to hang on to that everyone's accountable for, measured in slightly different ways. Can we get over that? Can we not let that undermine, our work together? But when everyone's accountable for similar things, we want to pull it as hard as we can and then let that lead us forward. So that's what the measurement scan was for, and it was hard. I knew it was even hard for us, Colleen, like to figure out, well, what are those measures and which ones are coming? So, but that's being offered to you so that you could build on that too. And it won't be too different in your state. It will be, but it won't be too different in some ways, because these are a lot of federal measures that are required, okay? And the final piece was really a multi-level leadership approach. We spent a lot of time thinking about what would the structure be to carry this forward. Should it be all state led? Should it be public-private? What already existed? How could we blend the different leadership groups? Like for Part C, there was a whole cross-sector group on that, just on workforce, what was going to happen there. And so that's where we did a deep dive work, and that's in appendix, attachment E, is a policy playbook, and it starts with some of the memos that we went back and forth on, thinking about the structure and the thinking behind some of the recommendations that really led to creating an early childhood development coalition that was very focused on this framework that was not overlapping, or that could really facilitate all the other leadership bodies that were there and be a basis for furthering that. So this is sort of why we went ahead and did it and what came out of it. And now I'm just going to give you a very quick tour of it, and you can access the resources more. I do have technically a half hour. Is that true? Are you guys still with me? Do you need a break? Okay, good. All right, so then let me go on, because I do have time. I am on time. Okay, so design parameters are critical. I wake up every day and I try to think, what are my goals? Who needs me? Like my family. Like, I just try to take a moment of intention. And when I do, I learn all kinds of things. But I wouldn't if I hadn't asked myself that question. Nobody can. Like, they're not just intentional, like, we said that we're animals that kind of go along. So I'm arguing for intentionality. So we really spend a lot of time, what really are the design parameters that you want to make sure are in play? And the very first one was families have to be at the center. Let's just and really make that real. Okay, and it is relational. And you can measure it, but it's in the moment. It happens moment by moment by moment by moment by moment by moment. It's now, it's lived. How can we create a system that really empowers that and values that? The built for nurturing connection. And it gives real processes, not just billboards on the freeway saying, we engage our families, which is what they say, right? But then you go to, well, what do you do to engage me? You can't even find out what we're supposed to be doing in well visits. We don't tell you. You have no way to plan for it. You have no way to find out what could happen and where you're at. You don't get your data back even if you gave it to us. You can't even find out what the developmental screening meant or the maternal depression. We just take it. We take your data, and then we, tell you we're going to fix it. Total paternalistic. So how do we really, really, really get up underneath that? The second, being interoperable. So how can we use an approach that's going to allow the home visitor to be the first point of contact, the Help Me Grow Center to be the first point of contact, the developmental specialist, wherever families go through any door? Is there some way we could share maybe at least a core set of assessments that we knew we could count on, that were valid, that were family-centered in how it was done, that would allow me to, in a resource and referral center with early care and education, engage a family, find out what's going on, and then share what we learned with the pediatrician, because then they don't have to do it again, which is what happens now. And then it's just more taking of data from families, and they stop answering because they can't see the value. It's like, what are you doing for me? So being interoperable, building on progress, being realistic. In Mississippi, it was like, we're going to build on what we've done now. We're not going to start over. We don't want to, like, no tolerance for blue sky beyond what we could hook it up to that's real, and leverage existing policies. So in Mississippi, that was the case. It may not be the case where you are. You may be in a state that's ready to roar and wants to do transformation. But in Mississippi, there were plenty of policies that were in place that weren't being implemented, that nobody knew about, that they could actually start to impact, and that the state even wanted help with. But nobody had given them a vision. You have to have an ask. Don't be afraid to ask, the power of vision. And, you know, you can do the foot in the door where you ask for a little and hope for more, or you can do the door in the face where you ask for everything and then come back with less, and there's different strategies for how you do your ask. But putting together an ask for family specialist and what it would cost is one of your TA goals, right? What does it look like? That's hard. It's hard to do that. What is my ask? Okay, I've got the governor, and all he wants is to make my dreams come true. What am I going to ask? Think about that. Think about the moment you get the attention and the power that you want, and what will you ask? And so it was very important, and we did a lot of work on what they could ask about what was already in place, because there was just too much worry that there would ever be a legislative change that would stick at the level at which they needed it to. And then in turn to activate short-term actions and improvement. I mean, give me something to do by next Tuesday, which is also one of your terms. Well, it's not your term, I think it's Don Berwick's term, but you're the one who taught it to me. So the characteristics ultimately of a transformed system were that it'd be equitable and aspirational. Okay, positive health equity. Developmental and integrated. Developmental both in how it's done, developmentally we launch and learn, and developmental in terms of life course wisdom and knowledge being at the root. Integrated care, integrated systems. Relational and inclusive, and constantly being at the check of that inclusivity. Who are we leaving out? There's a lot more to say about that, but it's, again, one of those intentional things. We have to ask the question and ask lots of people that question and keep asking that question. And then the next is accountable and engaged. Accountable, but the data and information that comes out is shared with the right people who then can engage in what it means and what we need to do. It's not just sitting in a book, and it's sitting in a book. I promise you, it's sitting in a book. And we help create the CAPS tool for kids with special needs, and it has so much possibility on how it can be scored and reported and acted on, but it's just put out as a Uber score, and nobody really does anything with it. And that was one of we were glad it got into NCQA, but then we didn't get to make it sing the way we wanted to. So there's a lot of data out there if you could get access to. Would keep everybody engaged in the solutions. And then sustainable and energized, because we can get very down. I mean, there were some conversations where people really feel very burnt out. And the magic there again is the relationships. We need to acknowledge that we're feeling that way, that we've been around for decades. How can we keep an energized workforce, an energized leadership, energized families that are going through so much? And again, I think the key is who we are moment by moment, and how much power we have, and to own that and to cultivate our skills to stay in the game, but also create structures and payment levels and things that are fair, so early intervention specialists can get paid on time at a fair rate. Because in Mississippi, that's not happening at all. It's like, bless the heart of those people who do that work, because they love. But do they get rewarded? No. And so knowing all these details really is important to creating that. So these are the features. And now is the quick review, because you can go access all these resources, okay? And I've already kind of told you what they are and why they're there and how they all came to be. We have a very simple website, just very simple. And it has all of the overview of the engagement and action framework, kind of a pull-out just of the framework, plus a Mississippi Thrive a longer description of what they did in those other areas in more detail that led up to the framework and when we brought it all together. All the attachments I just told you, as well as some of the toolkits we created to get healthcare with community starting to work together in an integrated approach, and then the Early Childhood Development Coalition Charter, which was a thing. It was a thing, okay, because everyone had to review it. It was very family-centered. It went all around and around and around and over and over and over. And I remember one week in my life, I was like, oh my God, we're on version 25. And it was all like very subtle. Do you know what I mean? And so it was important, but you can see what you think, because I think it might leave you feeling inspired, and maybe it would be a model for some of what you want to do. So that's kind of what's available there. And I'm just going to look through it real quick. This is a one-pager. It's not everything, but it's a one-pager that you can kind of gawk at and see it all together. It is important that a framework be able to be articulated in a higher level visual even than this, but to be able to see what's the purpose, what are the strategic goals, what's the approach, and some of what we call simple rules, which are key for systems change, is everyone agrees on how we do things around here, because we can't control every action that takes place in the field. We just agree that we're going to do it through any door. We want a through any door approach, meaning we all agree what we're up to and what we're sharing, and everyone is a leader in that, and everyone knows that they're important and that they're a leader, and that their every moment with a family and each other matters, and that they matter, and that in every encounter, if I go to take my child to see Dave Willis and they have a good relational experience, and then they go somewhere else and they're not, the trust never builds. And it's really important that we create a trusting system, because families have had it hard. We've all had it hard. We need to create that in every encounter, to be conscious and aware of the connection, the quality of the connection, to keep the integration going, which then is the no broken link. I commit that nobody leaves my presence as a family or as in a meeting without knowing what's next. Something, anything. We have to say, where are we going? Something. And that's a practice at all levels. So those are some of the pieces there, and then the implementation roadmap. And there's that QR code again if you want to access some resources. So the components are purpose, strategic goals, and design parameters. This is what's laid out in the overview. A theory of change, which I'm going to briefly discuss. An approach to services. The simple rules, and they're explained in more detail, along with collaborative principles, like principles for collaborative action. And I tried to link in all of your good resources in there, like the CSSP, beautiful resources on neighborhood collaboration and things like that. And then also an online toolkit, which is an online toolkit. You can use it. It's a national toolkit. If you want to, you could. Maybe it's not everything you'd want, but maybe it would be useful for you with your practices until you can either create your own or decide that works for you. But we did create an online toolkit. And then an implementation roadmap and policy playbook, and a new coalition and charter. So I've already told you that. So that's me telling you 3 times. So these are the goals. I've already said it, right? You think you got it? Like positive health equity measured in 3 different ways at a minimum: child flourishing, family resilience, and school readiness. We have those measures nationally at state level. We can repeat them. So I wanted to just put a point that we had a nickname for this. And if anybody knows me, you know how geeky I am about acronyms. I'm sorry, I'll never get over it. But we called it one bit. We could do one bit, which is get all kids in universal, comprehensive services. In the way we know we can define it. That's real engagement for real health, real engagement with a seamless system. That seems like obvious, right? Because we're all saying it. But it's one big doable thing that all kids get that. And so it's one big doable thing. Its super nickname is one bit. And it helped. It helped the group to think we're doing one big doable thing. It's one bit. And yes, it requires systems change. Yes, it requires systems change. I can't do it as a provider by myself. I can't do it as a family by myself. We have to have systems change. And when we have that systems change, it will be the groundwork for all kinds of other things, because we don't want to stop at 0 to 5, right? It's a lot of the same kind of thing. So you're seeing all this, but I'm just going to keep going. So I wanted to just tell you that that's a nickname for it, is one big doable thing. And it was energizing. It was energizing for people to remember. It looks so complex when we get into it, but actually this is all going together to create one thing. universal, comprehensive coverage for every child, aligned with Bright Futures guidelines and positive health equity goals, with real engagement at every level and a seamless system. Okay, so I know that's, do I need to do something here, do you think?
No, your friend's internet. Thank you, everybody, for waiting.
Can you?
You can exit out of that.
Oh, I can.
Yeah.
I didn't know if I was in
Thank
control.
you so much.
Okay. All right. And that's also me modeling. Just, you gotta go with it. Right? That's like if anybody knows interpersonal neurobiology, it's like the evidence of, and we all have to work at it. I work at it every day, is to be flexible, adaptable, stay energized, and systems thinking. Keep your intention wide. And so that FACES acronym I always remember, and we used it in Mississippi. It was like, okay, who's coming out of their faces? And it's like, I'm getting overwhelmed. Okay, let's just connect, acknowledge that, and that can keep you going in the conversation versus it just goes on and there's nothing really happening. So that's what I'm doing here. Okay, so the theory of change is really simple, and if you come to the breakout, you can play with the theory of change or any of these pieces. The workbook can help you pick where you want to plug into the pieces of this framework and think about how it might work for you. But the theory of change for the cycle of engagement is a model, and you can use different tools to implement this model. We actually named tools and came up with tools that could be used now, but you may have different tools, but we're going to share in the toolkit and other things what our tools were. So Child and Family Services focused on building trust and personalizing care to strengths, needs, and priorities, and an integrated whole child and family assessment that can be shared with families and across care teams. So it's a similar kind of agenda. It's not 10 different ways of thinking about measurement. You can do all your own 10 different ones, but could we come up with one that really could work? And then building partnerships, which will save time to deepen time for relationship and addressing the family's unique goals and needs, which will then, lead to ongoing engagement, including engagement in the follow-up resources that we've encouraged be used, and sticking with parenting programs or reaching out for the food insecurity supports, which often don't happen. For any of you who's working on the front line, you screen, you refer, and then somehow it doesn't happen. Are we good?
Yes.
Okay. And then finally, that this will lead to measurable improvements in child health equity and flourishing. So there is a theory of change always going on, right? There's always something going on inside of us. What is it? Making it explicit. What are you really thinking? And you can practice this kind of thing with anything that you're trying to come up. What's our theory of change about that? We think we need to do that. Let's just quickly scan why. Just so make sure that because you'll be surprised when you externalize the theory of change, it can be very different across partners. And it doesn't take that long, and you can make it a habit, but always figuring out, I think we should do this, what is my theory of change? And so that's what it is. I already went through the simple rules and the 4 elements of the approach. Okay, so I just want to say one thing, which is a key part of the implementation is you and me and us. And the success of the intervention depends on the interior condition of the intervener, especially when it comes to children's health and promoting health. Who you are, how you are, your own presence, we know neurobiologically is predicting whether someone can even hear you, where they're at. Your ability to help see and meet a family in the present, if they're dysregulated, is very key. So we are the medicine, is how I like to say it, and that's really important. So I wanted to share some data that we do have to drive this home. So this is data looking at the family-centered care component of medical home, and basically is showing that when families report that they really feel listened to by their provider, and you do interviews, it's that they feel seen, is really what they're saying. And when they say always, they don't mean always. That doesn't mean you always listen to me. It means I know you care, and I know you want to, and if you're busy, I know it's not because you don't like me. Like that sense of connection. And so we've done a lot of work with response options. So I look at the always, because usually scores on do you feel listened to are really not statistically different from the sometimes or never reports in terms of predicting the things we care about. And it doesn't mean you're always perfect, that you always do it. It's really that you've established a sense that I see you. And sometimes I have a hard day, but I let you know, I see you and I'm having a hard day. So this listening quality for families that reported that were, much more likely to also report that they felt hopeful and a sense of strengths to draw on. And that power of that relationship, I think, is very much there. This is cross-sectional data, but I know that there's a lot of other data showing what happens with a family member or you and me in a group when we see each other and we listen and we feel like we really mean to, even if we can, to our own sense of hope and staying in the game, our willingness to ask for help from you. And these are key family resilience qualities. So basically, for families that reported and experienced always feeling seen and listened to, they were much more likely to also express having those resilience qualities, especially hope and a sense of strength, being willing to reach out for help when they needed it. And this is after adjusting for all of the things that you would adjust for in a model. So I just wanted to kind of point out a piece of information that was there, that we are the medicine. What I'm going to show you next is just really some examples of the next big piece, which is how do we integrate, like between labor and delivery, which is a perfect opportunity to engage families in preventive care as having a provider, pediatric primary care, and then early care and education when it comes online, and having that intentional link. So we have some stories also of what it looks like in that integrative way. And then also there's a visual here that I will show you too that looks at every single key partner. Can you guys see it? Okay, now let me make sure we're here. All right. Was that fun in a weird sort of way? A little break? Okay. Okay, so so this is the through any door approach, which you can read more about, but basically it falls out of everything we've been saying, but we need concrete interoperable ways to engage a family and share that agenda with each other. And so this is a little story about how it could work starting in labor and delivery. Most of the pediatricians we've worked with said if we could just start at birth, that this is the way we do things around here. We engage you. We want to hear from you. This assessment isn't for us to check a box and get paid. We want to support you, and this is like starting right away, right there if possible. And then other flows, it goes anywhere. A family might somehow get into early intervention because they can before they even have a primary care doctor. So we want to create this sort of flow of intentionality, potentially with common tools that can be used to allow data to be shared. And some of these are put out in this toolkit, which you can get online really easily. And it's just enough to get you going with links to the other things, but it's all done in a CQI kind of model. And it also tries to meet practices and communities where they are, okay? But I do want to say one of them is something we've been working with HRSA on and AAP on for years and years, which is to translate Bright Futures guidelines for every single visit from the first week of life, 1 month, 2 month, into a family-completed online tool that produces a report for the family and a report for whoever's doing it with them. It could be a provider, early education, and a way to share the data until our EMR systems get their act together. We are working with National Epic. We've been working with them for 12 years. They will get their act together maybe one day. In the meantime, we have external processes we can use that systems use all the time. They use them all the time for adults, so there's no reason why they can't do it. But I wanted to share a little bit with you that all of this came about, and Colleen was our core partner for the first 4-year study, is to create a personalized connected encounter. That was the grant to HRSA. We want to create a personalized and connected encounter that is comprehensive around Bright Futures guidelines, that's family-centered. And we ended up with the Well Visit Planner. And then we had a randomized trial, and it showed a lot of benefit. And then we also wanted to create a tool that could assess quality according to what we thought we were doing, that could be very friendly to the provider, where they could get an aggregate data report themselves without waiting for NCQA to come down and tell them something that they don't really care to hear, because they're not measures that they care about. So that's also a tool that's actually been around a lot longer, and so it can be used. And I'm just going to show you a little bit as soon as, okay, I'm online. This is Barbara Leach, who's a close partner.
Hi, my name is Barbara, and I'm a family advocate. But even more importantly, I'm a mom, grandmother, and now a great-grandmother. I want to talk to you today about the Well Visit Planner. What is the Well Visit Planner? Well, how many times have you sat in a waiting room filling out forms that you didn't even know what they were for? Or walked out of an appointment and said, gee, I meant to ask the doctor about X, Y, or Z. The Well Visit Planner is an online tool created in partnership with families and healthcare providers to prepare you for well child visits. The Well Visit Planner only takes about 10 minutes to complete and puts you in the driver's seat. Not only are you in charge of your family's healthcare information, you also know what to expect during each well visit checkup. The 10 minutes it takes to complete the Well Visit Planner brings your strengths and priorities front and center. So you and your healthcare providers can work as partners for your child's healthy development and well-being.
At any time for people, and there's a lot more we can talk about in the breakout, but there's other videos and things like that. Can you see my slides or no? Okay. Okay. So what I want to tell you about that tool is we did have a Mathematica study, which scared me because the worst thing you can do is evaluate something before it's really ready, and that's sort of been the story of my life. And but they did evaluate it specifically for anti-racism and for community integration. And I have some nice slides here that you can get later that really talk about how this tool and model really does create an equity-focused approach that does lift family and community voice, where they get their own data back. They can use the data at a population level also to find out what's going on in their community. If a church wanted to be the sponsor of it, they could be the one to reach out to a provider and talk about it. It can start anywhere, but it was created and tested to be used by pediatric providers in partnership with their families. And when we did it in the children's clinic with Colleen's famous bagel ringing and everything else, was just amazing. She was part of the intervention. I had to at some point go, I don't know. It's like, this is working because of her. I can't figure out if it's the tool or Colleen. But I'm joking. But basically, we got 3,500 completes in a very short period of time. So it was not an issue when the provider said, hey, this is how we're going to do it before your visit. Fill this out. They get a visit guide. The provider got the data right into their electronic record, which was not hard. And now we have a one-page clinical summary the provider can get, and it's not hard to put it into the record. You get the attention of the ER team that you have at OHSU? I don't know. We tried. And we have it all worked out, what it would look like in Epic and where you would put it and things like that, because they're not going to create new data fields the way that the children's clinic did in Centricity. But we do have a lot of experience on that. But in the meantime, you have a way to get an aggregate summary and also the family, and then share the agenda, go right in, focusing on needs and getting links to resources. So it's definitely there, and the Mathematica team, without our involvement, did a study and really looked at how it performed across different starting points, including faith-based organizations. So I want to make sure you know that. And that's important because of the range of partners that we need to focus on. This is more in depth, and we're going to go into it in the breakout, and I'm going to kind of just do a few wrap-up things here because I have one more video I want to show you, and I don't know if it's going to work, but I'd like to leave you with an uplift from Mississippi. But this was the deep dive. Attachment C shows every single partner, what are their statutory requirements, what are their performance measures, why would this be relevant, and then an accompanying possibility prototype, which is a story. And the goal roles we tried to assign, which were hard because everybody can do everything, but what will they really do? What are they funded to do? Between key agencies right now that all align with the EnAct framework, so you can go somewhere with it. And other important programs too, Head Start, WIC, and CCDF do not have reportable performance measures, but their standards that they report are aligned. And so they are held accountable in the ways that they are. It's just not a public reported kind of thing. And these are the prototypes, what they look like for each of the groups. And you've seen this, the implementation roadmap in your little 2-pager. So this is just a visual, but we went really far to create SMART goals and kickstart steps for every single one of these in Mississippi, but I couldn't put that in the overview report. That would be just a little too much. You get to do that. So what we have is this workbook, which you can get a copy of, and we'll go through it more. You can pick where you want to focus, with 10 exercises to tap into this framework wherever you want to portal in. You can look at a theory of change, you can look at your partners, you can look at the implementation. The other things I want to make sure you know are in there too. This is just a table where you can start thinking, like, where are we already with this? And is there anything, are we doing something already? Are we good here? Is there anything we can think of we could do really quickly or in a year? And then I gave you a few examples, but there's a lot more detail if you want it. I just had to cut it off for the report. Then there's policy. Okay, so the simple story for me with policy, so basically I just make things simple, which I try to do. There's 7 key C's to policy change that are going to go to the front lines. There's coverage and coding. What is covered and what is coded, and what do you pay? Cost and payment. Coverage and coding, cost and payment, contracting and accountability. How does it get translated into agreements? Legal agreements, MOUs, and what's the accountability, and how does that get transparent so it can be used as a feedback loop for quality improvement, not just as a thing on the desk. Capacity and training, especially for those that aren't licensed but need to be credentialed and integrated. So credentialing and integration are key policy issues. Coordination within and across systems. What do we agree are the data we can share? What do we agree we can do together? What can I know about your patient so I can coordinate with you? And those are policy issues. And communication within and the public and consumers. What are we going to be willing to share with providers, the public, and consumers about how we're doing and about what's available to them? And these all actually require some level of policy. And so we do have a policy playbook that has 21 policy levers, and the first are all around financial levers that you can pull right now with Medicaid, and that you might already be, but if not, go talk to Colleen too, she knows a lot about this. But you can talk to me. Non-financial levers, like contracting, it's happening all the time. A lot of it's too private. You can't find out what the per member per month rate is and what makes it up. How are they paying for preventive care? It's in there. Can we make sure that you could get that algorithm so you could recommend a different way to do it? And so there's a lot of advocacy and policy change in the non-financial levers too. And then the next are other state levels of critical importance. That's kind of a boring title, but it's leveraging the Title V process, the MOUs, and really, it's not a lot of money in Title V, but they have important roles to play, and they can play those roles. They can help train, they can help communicate, they can help advocate, they can help with policy, and often nobody else can because they're too busy running the business at Medicaid, right? So if you get that partnership going and they can get a similar vision across some of these state groups, these are really important agreements that are actually supposed to already be happening, and they spend a lot of time putting them together but not implementing them. And then finally, strategic levers Medicaid can use to promote implementation and improvement, which is the change process. So if you look at the 2 big downfalls, funding and change process. Funding comes and then it goes. Change processes get supported and then that support goes away. And you named it in your TA priorities, sustainability of an implementation infrastructure with reliable funding built into contracts at the minimum, and do what you can with that. It won't be perfect, but there's a lot that can be done now. And I'm going to end with this slide and a 2-minute of a signing ceremony, silly slide deck that got put together, but I think you might like it to celebrate our colleagues in Mississippi who are not here today, but who are in my heart and are in hopefully your hearts too. So I'm going to stop sharing the Early Childhood Development Coalition 2-pager. You should read it. It's a 2-pager of a much longer document that really gives you the gist of what they've committed to across family, community, and providers and systems, okay? But at least will give you a sense of what they're up to.
So we have about 7 minutes for Q&A, and thank you for being so flexible.
Oh yeah, and I can stay at lunch too.
Okay.
We have a Meet the Expert, which is separate, but if anybody wants to just huddle up and, on a table or something, I can go through data, measures, policy, the partnerships, this video if you want, whatever you'd like.
So we're gonna,
Oh,
if you wanna just raise your hand, we have some folks who are gonna come through with mics so that you can ask your questions. And we do have time
Yeah.
for Q&A. We're going to bleed into the break that we had built in.
Yeah.
So if you need to take a break, again, the bathrooms are right out the door and to the left
Yeah.
of the stairs.
and for the people on Zoom, I was just saying, I don't know if you can log back in, but I also am willing to, at lunchtime, when there's not an event going on, to be available. If you wanted to log in, you can let me know.
So you have a question?
Yeah.
I was really interested when you were talking about the relational health risks versus the different social factors, and I was wondering if potentially there are other social factors that are now causing these relational health risks. So a family might not be in poverty because parents are working multiple jobs and they don't have the time. And so my question is, do we potentially need to redefine social risk factors? And then also, is poverty just different now? Thinking of inflation, thinking of like how we define poverty versus what we hear families
Yeah.
say.
Oh, those are really good questions. So basically what my experience is when we look at a lot of social factors, and this is how we did this children with special health care needs screening. There were 139 things that children with special health care needs needed and experienced. But all the children who met any of those 139 had at least one of these 5 things. So then it becomes a screener, right? And so the filter for this was the available data that was really had strong evidence based around it, but it's not meant to be exhaustive, but they also all count. You don't have to meet all 4, right? You can, and so poverty is economic hardship. And what that's defined on purpose, because only 40% of people in poverty actually meet that economic hardship item, and a lot of people with 400% of poverty or more do also meet it. They're taking care of kids with special needs, parents, they are in economic hardship. And so that way it's measured, at least in the way I showed it to you, is economic hardship. And I keep trying to explain that, but it's too long, and you've given me a chance to, so thank you. And I'm not going to use the word poverty anymore. I'm going to change that slide again. It used to be economic hardship, and then that caused a lot of concern. So, but it could just be experiences of racial discrimination. So it's all of them. But yes, there are. But what I would like to say is that when you come to measurement and we want to create coherence, that sometimes we have to start with something, but you want to pick the things that are so cross-cutting with other things that you're not missing those either. You're pulling them along. But then when you want to go into the depth with a single family or a community, you want to see the depth. So it depends on what you're doing. But absolutely we need to look at that, and especially the economy. There are a lot of families that you think aren't in economic hardship that are included in that measure. Yeah, very, very astute. Yeah.
Thank you for everything. I was super excited. So you were using the word flourishing, and it's in the handout. And I can't remember in the beginning, did you define what that means?
Oh my gosh, I wanted to so bad. I really had to hold myself back. Like, it's a whole talk I give on flourishing. So it was a long process that we worked with Paula Duncan. How many people remember Paula Duncan, who is my hero in heaven? And also Child Trends and lots of other people around the country to define and adapt a concept of flourishing, which has been more well adapted for adults in measurement, having a sense of meaning and purpose, having relationships, being engaged in life, keeping an optimistic possibility view even in the face of difficulty, looking for what could go well and hope and staying engaged, all that resilience. Contributing, even if, no matter, valuing yourself, knowing you what matter, things like that are characteristics of flourishing in adults. But for children, they're developing, right? So what would those be? And so through the long process, starting out with 39, 26, and finally Peter Van Dyke, if any of you remember Peter Van Dyke, called and said, you got 4 items, max. 3 for adolescents, so we could get a private and confidential well visit item in. I mean, that's how it goes on these national surveys. So it's basically 4 things, and for young children, it's focused on whether the child smiles and laughs a lot, so it's like an emotional indicator and is affectionate and tender with the parent, and also whether they bounce back quickly when they don't get something really quick, like are they able to be soothed? And so there's 4 things in there, but basically there's a definition, and we have a whole report on it and a validation report, and yet I would really like to be able to improve on that, and my preference would be also to embed these observational pieces in care, but you need time for that. But it's very powerful. It does definitely have a lot of sensitivity of the absence of it is an issue, but the presence of it isn't necessarily as strong as you might want it to be because it's a cross-sectional study. And for youth, it's being curious. Oh, that's the 4th one for young kids, is being curious and interested in learning, just basically engaging in what's in front of them. And so those are the 4 pieces for kids. So that's how we define it. And there's a whole explanation for how it actually feeds off of different parts of the brain that develop, and being curious and interested is more the focus, and being affectionate and tender is more the emotional. And so there's actually a logic to it that would never be seen if we didn't give me the opportunity to share a little more.
Did you ask your parents what that means in the back?
Oh, of course. Yeah, that's why it took so long. We started working on a lot of these measures in 2001. We didn't have the data till 2013. That's why we were really busy that year, because it took that long to get the measures developed, validated, accepted in the survey, collected, and then reported. And we also run the Data Resource Center, childhealthdata.org, so you can actually go get the data and find it. Yeah. Yep.
So I love looking at all the different data that you managed to collect across the different states. Looking at the data, I wonder if you ever looked at children who are on Medicaid. Do they get lower levels of care? Especially when you look at mental health.
Yeah.
Because I noticed that, if they're on Medicaid, there's different licensures for different services.
Great question. I have a data table for you with all children and privately insured as well. I just couldn't bring myself to share it because I didn't want to overwhelm you, but I ran that too. So you can compare all of what I showed you in the data table, public to private. Just it's hard to put it all on one table. So there's a table for publicly insured children and a table for privately insured children. And I wanted to create slides, but it would have been too much, but it's easy to do, where you can see differences. And in some states, especially where the prevalence of well, I think it's all states, but when your prevalence is really low, and 9.3% of the budget and 24% of kids in Massachusetts, that you might have to say why it's so important to focus on those kids, because they're really different than kids who are privately insured. Fortunately, in Massachusetts, they do a pretty good job, but I have that data and I can share it with you. So if you just let me know, do that Google form, the thing, and just put in anything else you want, and I'll make sure you get it.
And then did you also look at not just mental health, but dental care?
Yes, dental care. There's 49 measures in there. I only called out a few of them for the presentation. And so dental care is in there. How many kids have an IFSP or an IEP, and all kinds of things. How many families that have are on some kind of food or assistance, and all of it. So and comparing it is key. Also across more subtle age groups, and also race, ethnicity, and other things. So that's all available in the data set. And we can, if there's special things you hone in on as a group here, we could put them together in a at-a-glance kind of table, or I can just give you access to the data that we make easy to use. We make it really easy to point and click to get data, or if you do have anyone who can just download a data set in SPSS or Stata or SAS, we have all the data sets cleaned and ready to go.
And then last question, the other one that I found was very interesting was when the dental comes to the school, and they do that in early childhood also. So you guys have data on that, for how many kids are seen?
What we do have, which is actually a very powerful indicator, is parent report of how coordination between the school and the healthcare provider goes. And if you pull out things like listening and that item from the medical home, they're actually the most powerful and predictive of a lot of things. But there's nothing asking whether dental care is being done in the school. Yeah. But there is a lot in there about dental care, actually. The quality of children's teeth, the services they get, and things like that. It's growing, too. Yeah.
So we can have one more question, and then we'll go ahead and break.
Oh, good. Yeah.
Hi. First of all, awesome, terrific talk. I'm just so impressed by all of this.
That means a lot to hear that from you. Thank you.
So I just wanted to ask for a broad question, something that, I know we've spoken about this, and that you spoke about in this talk, was, that on the one hand, there's kind of, identification of families with problems and challenges and trying to do something about them. Obviously, critically important medical model, that's where I come from.
Yeah.
And on the other side of the promotion of, flourishing, of early relational health, of early child development, universally. And as you mentioned, the lots of evidence-based, programs that are out there that, can be utilized for this purpose. And it seems to me that, the big question is how do we gain, kind of parity, between, addressing problems on the one hand and promoting flourishing.
I mean, one thing that's the center of the cycle engagement model, which we operationalized for young kids through some tools, is the personalized connected encounter. So it's very much a shared decision-making model where the family has agreed to share things with you. So you collect data that is about their needs in a way that they know that you have it and they want you, and then you say what. So the part of the personalized connected encounter is to celebrate strengths first, as you have that information, but also acknowledge risks and problems and ask, do you want to talk about it? Do you already have ideas about what you need? What would you like? Getting them involved, because then they access, I do have ideas. Actually, I do have resources. And it comes up all the time. And I remember, Colleen, you probably remember, where providers were getting a lot of ideas about resources in the community from the families, about things that were in the community that weren't there. So if you really, really dedicate in the problem-solving medical model mode to shared decision-making, and you make those pieces a mantra, and whenever you're dealing with something hard, do you want to talk about this? What do you know about it? What do you think you need? Do you already have things that you think you could use? A lot of times then it's the provider following their own strength. And so I think that's really one way to do that. Of course, the other way is the through any door, where the promotion just happens all the time. You don't wait till you have something. You just are always really focused on that. I don't know, I would like to talk in more depth about the structure of how that would happen, but I do think that pediatricians, medical model or not, need to build in that mindset and can do it even if their focus still ends up being more on risk. Yeah.
All right, thank
Okay.
you so much.